Good afternoon, everybody. My name's Kevin Hedges, and I'm an occupational hygienist with the Occupational Health Clinics for Ontario Workers. Thanks for joining us. We're really trying to keep up to speed with the science around COVID. We've been running webinars for quite some time now, and this is part of a series of COVID science solutions and success stories to continue. As I said, we're trying to keep up with what's going on, so we thought it would be really a good time just to have a reality check and talk about modelling surveillance to guide future response. So we've actually got the first speaker is Dr. Gosia Gasparitz. She's going to be talking about, Dr. Gasparitz is going to be talking about modelling and shifting data. Vaccines and public health measures remain critical. We're also very grateful to Dr. Alec McKenzie, who's going to talk about measuring SARS-CoV-2 RNA in wastewater as an early indicator to help determine COVID-19 activity in the community. And our third speaker, Dr. Crystal Pollett, is going to be talking about development and application and lessons learned of a passive air sampler to assess personal exposure to SARS-CoV-2. So quite a few of us do volunteer work behind the scenes. So this is our professional job with OCAD. But our volunteer work also involves the Canadian aerosol transmission. We have a brand new website. The coalition has a brand new website. And on the 1st of March, we actually provided a webinar on Mass Smart. So it was the first webinar through the coalition. So I suggest you might want to have a look at that. It's really aimed at the public, proper protection, respiratory protection for the public. And next Wednesday, March the 9th, another volunteer organisation, Workplace Health Without Borders, running a ventilation and risk assessment for COVID-19 prevention. It's free. Anybody can join, and I believe from Marianne Levitsky, we've probably got over maybe 300, maybe 400 registrants for that so far, but please join. Okay, now to this webinar. With the impending or unpredictable next wave of SARS-CoV-2, modelling and future predictions are essential. With the decline in PCR testing and contact tracing, it is imperative that other measures, including wastewater surveillance, be promoted. Clear communication and attention by employers, workers, the general public, and community is necessary. As part of a risk management framework, wastewater testing can inform the essential public health interventions regionally using a risk-based approach. In turn, this information can be used to advocate for intelligent and evidence-based decision-making to direct workplace practices and policies. And so we've got Gosia and Alec, for the first part of the webinar, and we've got Dr. Crystal Pollett talking about monitoring. So monitoring exposure to SARS-CoV-2 is another tool in the toolbox that can assess the effectiveness of interventions in the workplace, including improved ventilation. So just moving right along then, I just want to introduce everybody again to Dr. Gosia Gasparitz from the Faculty of Nursing, University of Calgary. So Dr. Gasparitz is a developmental biologist and a researcher at the University of Calgary. She's a co-founder of Zero COVID Canada Group and a member of endcoronavirus.org, a member of Protect Our Province in Alberta, and also a member of the World Health Network. She earned her master's at the Intercollegiate Faculty of Biotechnology in Gdańsk, Poland. I'm sorry for the pronunciation there, and a PhD in biology at Albert Ludwig University of Freiburg, Germany. She currently lives in Calgary, Alberta, and it gives me great pleasure to hand the reins over to Gosia. And once again, we appreciate spending your time with us. Thanks, Gosia. Over to you.
Thank you, Kevin, for the kind introduction, and I'm very happy that I can present today. Thank you very much for inviting me. So yeah, I'm a developmental biologist and worked a lot with the biological dynamic processes. And since the beginning of pandemic, I observe what is happening and how COVID spreads. So today I will talk about first the reality check, what is our current situation in Canada with COVID, and how I interpret shifting and limited data, and that vaccines and public health measures and good policies are still very, very important, and how all of the combination of all of them can get us out of the pandemic. So individual risk of a person is a multiplication of probability of getting infected by probability of severe outcomes if infected. So this can be protected by vaccination. This can be reduced, but there are things that we don't have influence, like age, health, access to hospital and therapeutics for our probability of severe outcomes if we get infected. This gives us much, much more power to do something about it. So probability of getting infected can be strongly reduced by reducing community spread. So for example, a person living 0 here and individual risk is 0, even if this person is, for example, immunocompromised, older, or cannot get vaccinated because has severe allergic reaction. And so this element can be reduced by good policies that focus on stopping the transmission or limiting the transmission. And it can be done by public health measures like mandatory mask mandates and limit of gatherings and so on. Also by engineering solutions. So basically cleaning the air, making spaces and living spaces COVID-free by eliminating COVID particles from the air. Okay, so how can we assess how much COVID spread we have in the community? It's now a bit difficult. Usually one could just look at the report of how many daily cases we have, but recently our measurements are very low, so we test very little. We make very little PCR tests. So this level, we have 500 in Alberta, 500 daily new cases, and we have just 2,000 to 3,000 tests done. At the same level, at this level of cases, in previous times we had 9,000 tests. So this information is very limited about and quite inaccurate how much cases we really do have. We know that it's much more than reported, but one thing stays. So basically the general shape and general trend still is, we can say that it's probably correct. So where are we now in Canada? We are still in the highest wave we've ever been. It was going down, now it starts going up again, unfortunately. This wave still kills around 45 people every day in Canada, and our hospitals are still overwhelmed. Here we have hospitalizations with COVID level, and it's still higher than in previous waves. So after the Omicron wave, the pandemic won't be over, although there was some narrative saying that, okay, after Omicron, the pandemic, it will be over. It won't, and the future is still highly uncertain. This graph shows the mutation amount, number of mutations over time in SARS-CoV-2. So each dot here is one sequence sample of the virus. And we see how that the mutation rate over time was quite stable until Delta. But now with Omicron, the speed increased. And so we got Omicron that is more transmissible, so has transmission advantage and is more immune evasive than Delta. And just several weeks after Omicron appeared, the BA1, we got Omicron BA2 that has 40 different amino acids than BA1. And it's more transmissible. It seems that it's more transmissible, more immune evasive, and more pathogenic than BA1. And also some people who've been infected with BA1 got already infected with BA2. So it's a very short period between reinfections. So that's pretty dangerous. And also what is interesting here, we can see how SARS-CoV-2 explores the evolutionary space. So here we have alpha, so the dark dots. So it mutated into evolved into alpha. It explored this area, then it evolved into delta and explored this space, and then from somewhere long time ago, it shooted the Omicron branch, and it started exploring here and then exploring here. So basically, anytime one of these older dots can shoot something that will be totally different, that can be more transmissible, more pathogenic, or more immune evasive than even Omicron is. And we cannot predict what it will be, but the more we let transmission go on and the more we let people get infected, the more variants we will have, and the more dangerous our situation is. So it's really very, very important to stop or strongly limit the transmission. And okay, I would like to address one narrative that was quite popular in early December when Omicron appeared in the West, that people have been saying that Omicron is mild and that's why it's good, and that's why we are sort of safe letting it grow. But it's not true, because if something is very transmissible, even if it's less lethal, less pathogenic, it's still more dangerous and will generate more deaths. So this is just mathematical model, theoretical example. So gray line would be deaths from the baseline variant. If we would have a variant that is twice more lethal, the increase is linear, so there would be twice more deaths at any time than with the previous variant. But if the variant is twice more transmissible and has the same lethality as the gray one, that's how it will look, because it grows, the advantage is exponential. So it grows exponentially and the number of deaths grow exponentially too. And even if the variant would be 10 times less lethal than the gray one, but twice more transmissible, initially there would be less deaths, but then the advantage of getting more deaths would increase exponentially. So that's the theoretical thing that I presented in December, yet still we allowed the spread. And that's what happened. We got the Omicron variant, so many people got infected that we got plenty of deaths. So here we have number of deaths in Canada, and we see that the Omicron wave was the third most lethal one from all the waves. So till now, it killed 6,500 people in Canada. So there is another graph I would like to show, and how I look at data at daily cases. So okay, daily cases are unproportional. Like what we see here is probably 5 to 10 times higher, but the general trend, I think, is still correct, what those data show. And I like to look at logarithmic scale, because on logarithmic scale, we can see if we really have the exponential decline or if we have the exponential growth. So exponential growth would look like a straight line on log scale graph. And it's very important to look on log scale, especially at low numbers, because at low numbers, at linear scale, it looks flat, but when we switch to log scale, we can see whether it's exponential or not. And what we are seeing now, so we had a decrease in number of daily cases, but since 1 week, it's not only flattened, it's slightly decreasing exponentially up. So that means that something, normally they should go down with the same restrictions in place or same measures in place, but this suggests that something is growing underneath, and maybe soon can sharply shut up, like grow up, and especially if we reduce protections right now. So this graph shows the principle of this phenomenon. So if we have the green line shows an exponential decrease in cases under stable level of protections, under stable level of fresh people being fresh vaccinated or freshly infected and have this fresh immunity. And if the same things would be kept in place long enough, we can stop all community transmission. But if we reopen too early, for example, at this level, all our immunity wanes, either immunity from vaccination or immunity from infection, or we have a more transmissible or more immune evasive variant, then a growth starting new outbreaks start, and we have this new growth. In overall cases, when we add the green line to the red line, it looks like nothing is happening up to now. It will still go down, but it's less sharp going down and then go up, but it looks flattish. So people are usually not alarmed at this stage, but actually since here we should be alarmed, since the growth rate is smaller than it was previously, because that means that something is growing. But so how to stay on this green line? It's totally possible. And we don't have to have this roller coaster of being on permanent roller coaster of ways, like reopening and then closing when the cases are too high and so on. But we can stop community transmission. It is still possible. So how was it done? It's elimination. It's called elimination strategy, and it was done in many jurisdictions in China, Taiwan, New Zealand. Initially in Vietnam, in Hong Kong, and in Atlantic Canada, so in Canadian provinces. So that's the illustration of daily new cases in Nova Scotia in the first year of the pandemic. So what they did, they had shut down, they drove the cases till zero community transmission, and only then, so that's what we did in Alberta. We also drove the cases down, but we reopened somewhere here. Well, they didn't reopen until there was zero community transmission. So after transmission was totally stopped. And then they lifted internal measures. So like open schools, have larger gathering limits. And so this can be done with bundle of public health measures. And now also we have vaccines, and we know that COVID is airborne. So on top of it, we add airborne precautions, which we didn't use at the beginning of the pandemic. But to protect the state, so not to have new outbreaks from imported cases, there has to be measures to prevent reinfection of the region, which is preventing importation of cases by quarantine, by vax passes and tests, and also making population resilient to reinfection. So even if a case appears, then the chance of getting infected will be smaller, and that's done by vaccination and by airborne precautions inside places. The outbreaks would appear, and they appeared from imported cases. Now probably they can appear also from animal to human transmission. But if we have good monitoring, that they can be locally stamped out almost immediately with sharp enhanced local measures, and for example with ring vaccination, like giving boosters in this region much faster than in other regions. And that's what Atlantic Canada practiced till summer this year, last year, till summer 2021. So here we have new cases adjusted per population. Colorful lines are Atlantic Canada provinces, gray lines are 6 larger provinces. So 6 larger provinces followed mitigation. So they implemented stronger measures only when the healthcare system was on the verge of breaking, and when doctors started protesting that it's really bad, then the measures were implemented. But in Atlantic Canada, always the focus was on controlling transmission. So they had almost no community spread during this time. Then they had some outbreaks, but we can see that they are not waves, they are outbreaks. They were stamped out locally. And for example, this outbreak, because of border controls, didn't spread out to other places and other provinces in the region. And the same with this outbreak. So that are cases. Here is the difference between, so elimination strategy provinces much better outcomes in terms of number of cases, in terms of they had much dramatically less hospitalizations, as we can see here, much less deaths, and better economic outcomes. So scientists from Institut Molinari in Paris analyzed that they had better GDP outcomes and better mobility of people, both in workplaces and in leisure places. Okay, so how can we stop transmission or strongly limit transmission? I will quickly explain remind what R0 value is. So R0 tells us how many people on average one infected person would infect if there would be no any measures and everybody would be susceptible to the virus. So original virus that was in Europe had R03, so one person would infect 3 people. Then Delta had around 6, and the Omicron, we don't know. Probably R0 is above 7, but we don't know really how much more. And RT or RE is the R value at any given time under a certain situation, under so many people vaccinated. So we can stop transmission by combination of vaccines and public health measures, or using each of them separately. So for original strain that had R0 equal 3, we've been able to get RT to 0.6. That's the measured value. So for example, in Austria, in Melbourne, in New Zealand, it was even smaller. It was 0.5. In Alberta, it was 0.7. So this cocktail of public health measures was really a bundle. It was closing schools, closing non-essential businesses, limiting travel, and etc. We've been able to drive transmission down, to bend the curve. And if we would keep this for long enough time, like New Zealand did, then from 100 cases in 37 days, we could get to stop all the community transmission. With vaccines, without public health measures, theoretically, if we would have 75% total population fully vaccinated and 93% efficiency against overall transmission of the vaccine, then we could bring the R from 3 to 0.9. So we see that it was possible to bend the curve with vaccines only with the original strain, but it was on the border, right? It wouldn't bring R value to 0.6 or 0.5 like public health measures did. But if we have vaccines then and add them to the public health measures, then our R value would be 0.18, and in just 2 weeks, the pandemic could be over. But we didn't have vaccines then, and we made a super big mistake that we let COVID spread and generate new variants. And although now we have so many good vaccines, but with Delta variant that was twice more transmissible, public health measures, 0.6 times 2 is 1.2, would have such effect. And the vaccines would bring like 93% efficient vaccine with 75% total population vaccinated, theoretically would bring R's down from 6 to 1.8, which is not enough to get to herd immunity or stop the transmissions. But still, if we have such public health measure topped with vaccines, the R could be 0.36. And that's almost what happened. So we had small R, we had the R with vaccines, then we had some public health measures much weaker than those, and we bent Delta wave. So we bent it to the R value of 0.8. So it was possible, but again, we didn't drive transmission down to 0. We let it grow again, and meanwhile, we had Omicron. So here, this shows hypothetical variant that would be more transmissible, so had higher R0, and would be partially immune evasive, so the vaccine efficiency would be just 60%. It's not representation of Omicron because I don't have good data for Omicron, how much immune evasive it is, and how big intrinsic transmissibility of it is. So such a variant would have R reduced to 4.4, which is by vaccines only, with public health measures only that bend the curve in New Zealand early in the pandemic, we would have R of 1.6, but still, if we would combine them, we could bend the curve down and stop, get R to 0.88 and stop the transmission if we keep it long enough. And that's what we can do now. Like we have, okay, maybe I go back to this graph. So this green line can be like this, can go sharply down. The more stringent public health protections and restrictions, the faster it goes down. Also, just now, like we see it right now, that when we have fresh immunity from vaccinations and from infection, it also goes sharply down. But once the immunity wanes, it can go up again. So it would be really good to use this moment when we have fresh immunity to push public health measures more and to strongly reduce or even stop the spread. Here's a little bit of good news. So here is the graph showing the influenza in Alberta in last five seasons. And we see then the last year's season and this year's season, there's almost no influenza. So basically by using public health measures that we used for COVID, we de facto got to flu zero. So almost eliminated it. And what makes me super happy is looking at this table, which has almost all zeros. So severe outcomes for influenza this season in Alberta, it's one person that was hospitalized. And if we could get such table for COVID, it would be wonderful. So if we could focus on transmission and focus on good policies that limit the transmission and engineering solutions, we can really stop COVID and make everybody safe. So if we reduce this, then even immunocompromised, vulnerable people will still be safe. Thank you very much.
Thank you very much, Goshia. We really appreciate the fabulous presentation again. And we do have a panel discussion at the end. And I thought if you don't mind, I thought I'd ask you one question. I don't see any other questions in the chat box. I might just ask you this question first, and then maybe just refer to the chat box as well. So, you've kind of been a great advocate right from the start with, with Zero COVID Canada, Protect Our Province Alberta, and coronavirus, the World Health Network. So you've been part of an interdisciplinary team, including, aerosol scientists, engineers, medical doctors. So I'd say you would have a pretty good perspective on public health measures. So I guess my question is twofold here. Do you think guidance from public health is good enough currently? And the second part of that, and I don't want to lead this question, but if not, in your opinion, where do you think the gaps are?
So yeah, public health recommendations are not enough. They are not strong enough right now. They are not really they are not strong enough to reduce transmission and protecting us from getting infected. So to be better, like it's clear that we need to clean the air, that we need to wear better masks, that we need to get educated about. And that's probably the biggest problem. Like people need to know that COVID is airborne, and people need to know how it is transmitted to enable them to protect themselves. So enable them to filter the air, to monitor by CO2 monitors how good the ventilation is, to ventilate, and to wear as good respirators as possible. But for this, one has to know why. So like, I know that I need to filter water because I know that water is dirty and there can be bacteria in it. And that's why I don't drink like not boil, like in contaminated regions, I don't drink and not cooked, not boiled water, for example, and not filtered one. So for this we have this conceptual framework, but for clean air we don't. And I think until we don't, it would be difficult to fight it and to prevent ourselves. And also the other thing is to know what is not communicated well is the harm of long COVID, that so many people are harmed by it. Like around 30%, there are estimates around 30% of people who got infected suffer long COVID at some or long-term symptoms after infection, and for many it doesn't go away, but still it's not listed. Like we don't have, for example, we don't have graphs of long COVID, right? We have deaths, we have hospitalizations, but not long COVID. And also we need to know that we can be reinfected, and each infection is a blast to our, like it's bad for our system, our body. It's not a blessing that gives us more immunity, because immunity wanes, but it's a harm. So I can get infected maybe once and be fine, but can I get infected 5 times and be fine? Probably not. And the older I get, each infection is worse. So if we have COVID circulating for the next 10, 20 years, then everybody is in danger, because somebody who is now 30 will be 50 and sometime got hit with it, and it can be deadly. So yeah, so I think we should have much better communication and much stronger protections, especially those that are easy to do, like masks and air filtration. And mask mandate is important, because it's not only that vulnerable people can protect themselves with masks, but everybody has to protect vulnerable people and not exhale the virus into the common air. And that's what masks protect against too.
So
sorry, it was long.
Yeah, no, that's really fabulous. Thank you. And just, I'm glad you talked about long COVID. And, if people want to have a look at the Aerosol Coalition website that I talked about, there's a doctor, a co-founder of Masks for Canada, Kashif. He's actually got a video with a Dr. Leonardi, who actually talks. He's got a presentation. The T cells are not all right. So people on this call might want to look at that and think about the impact on the immunity as well for long COVID. I might move on now. I see Lawrence and Zoid's got a question in the chat box, but we might leave those questions to the end if that's okay, and then we can, as part of a panel discussion, we'll refer to those two first. So thanks, Gosia.
Thank you very much.
And if you hang around for the panel discussion, that would be great too.